today's class is continuation from previous day's class, yesterday's class, right? So those who didn't attend yesterday may not understand. Okay. So we are discussing synaptic plasticity and consequently cerebellum. Okay. So for a brief recap, synaptic plasticity, it is the change of synaptic strength, right? So the strength of a synapse can be modified, either increased or decreased due to history of previous discharge. It can be either increased or it can be decreased, and it is called synaptic plasticity, right? And we had divided synaptic plasticity into few categories, right? So one is short-term changes and long-term changes. Short-term change in synaptic strength and long-term change in synaptic strength, right? Short-term changes of synaptic strength, we had talked about facilitation, augmentation and paired pulse facilitation, right? And on long-term changes, we have given you two terms. One is long-term potentiation and another is long-term depression, right? Long-term potentiation is responsible for your memory, right? Which happens in your cerebral cortex, in your hippocampus, right? We had briefly classified memory as well. The immediate memory, short-term memory and long-term memory. Immediate memory, you retrieve it from your reticular activating system. Short-term memory, you retrieve it from your hippocampus, and long-term memory, you retrieve it from your neocortex. Okay. So neocortex is the place where, or hippocampus is the place where long-term potentiation takes place, right? And in cerebellum, the organ which is responsible for smoothing of your movement and for motor learning, okay. In cerebellum, the type of synaptic plasticity that happens in cerebellum is long-term depression, that is decreased strength of the synapse, right? And we started with the signs and symptoms of a patient of cerebellar disease, okay. So how a patient will present to you with cerebellar disorder, a patient of cerebellar disease, how the patient will be presenting to you, right? So to know this, you need to know what are the signs and symptoms of cerebellar disease, right? Okay, the video I could not show you, this is the video, right? So see this carefully. So this old lady, she was asked to show her wristwatch, right? The old lady was asked to show or remove her wristwatch, and this is how the lady is doing, okay? So at the beginning, the movement was smooth, and you see as the patient is approaching towards her wristwatch, you see tremors, right? And this is a very typical tremor of cerebellar disease, and we call it what kind of tremor? Yes, from previous day student? Intention tremor, correct, intention tremor. So we call it intention tremor, and you need to be differentiating patients of cerebellar disease with a patients of Parkinsonism, with a patients of Parkinson's disease, right? So Parkinson's disease is essentially a disease of basal ganglia, right? So in basal ganglia lesion also, patient will be having tremor, but that tremor is different from the tremor we see in cerebellar disease, okay? In cerebellar disease, the tremor is called intention tremor. It is intention tremor, and in Parkinsonism, the disease of basal ganglia, the tremor is rest tremor. Even when the patient is resting, there will be tremor. But in case of cerebellar disease, only when the patient is asked to do something, asked for a motor activity, so at the beginning of movement there will be no tremor, but as the patient is approaching towards the target, there will be tremor, and it is essentially intention tremor, okay. So it is a major sign in cerebellar disease, right? So what are the other signs and symptoms of cerebellar disease? We will discuss today, and also the gross physiology, and the connections of cerebellum. I asked you to remember the connections between the cells, okay, PC, BC, GR, GC, that is Purkinje cell and Golgi cell, Purkinje cell, Golgi cell, granular cell, basket cell, right? How all these cells are connected with the deep nuclei. I told you to remember this connection, okay? Okay, so let us begin with the signs and symptoms of a patient who has got a lesion in the cerebellum, either cerebellar damage or ischemia in the cerebellum or some tumor in the cerebellum, right? So there might be different pathologies. So depending on the pathologies, there will be symptoms, but grossly, a patient of cerebellar disease will present to your clinic with few signs. So what are those signs? One sign already you know, that is intention tremor, the major sign you see in this video, right? And this video may come as your OSPE examinations as well, okay? Here the question asked, what is the patient, this is what the patient does when asked to do, remove her wristwatch. The lesion is in, answer is cerebellum, okay? The lesion is in or the damage is in cerebellum, okay? Now, let's review all the lesions in cerebellum. These things will not be given very clearly in your textbook, so please be attentive. So, cerebellar signs. So, check for all the cerebellar signs when you suspect a patient of cerebellar lesion. So, first sign is delay in initiation of movement. Delay in initiation of movement. So, if we take the previous example, the old lady was asked to remove her wristwatch. So, a normal person will start the activity immediately, but when the person is of cerebellar lesion, she will start with a delay, okay, as if she is not listening at the beginning, and after sometimes she is listening what has been asked for, right? Okay, so you see the delay in initiation of movement. Here is the point go when the advice was given. For a normal person, here is the point to start activity, but you see for abnormal, when there is cerebellar lesion, there is a significant delay, and then the patient is doing the motor activity, right? Clear? So, delay in initiation of movement, the patient was asked to squeeze a ball with a pressure transducer. So, in this example, along the y-axis, the pressure, and along the x-axis is time, okay. So, the patient was asked to squeeze a rubber ball. The patient was asked to squeeze a rubber ball. So, squeezing starts from this point in a normal healthy individual, and squeezing starts from this point for a patient with cerebellar lesion. Clear? And also you see that a normal individual maintains a constant pressure, okay. A healthy normal individual maintains a constant pressure, but a patient with cerebellar lesion, the squeezing effect is on and off, okay, and it is not static, okay. So, delay in initiation of movement, we can test that by giving the patient a rubber ball and ask the patient to squeeze with a pressure transducer connected, right? Okay, next, dysmetria and decomposition of movement. Okay, yesterday I told you that what is decomposition of movement, okay, what is decomposition of movement. So, if I ask you to do something, if I ask you to move from here to here, okay, if I ask you to move from here to here, your movement will be smooth, right? So, smoothly you will move from this point to this point. But when the lesion is in cerebellum, there will be decomposition of movement, means your smooth movement is converted into a robotic movement, right? So, simply if I ask you to show me your nose, so you see in this way, this is my nose, but for a patient of cerebellar lesion, the movement will be robotic, right? So, without cerebellum, our activity will be robotic. Decomposition of movement, right? This is called decomposition of movement, okay? dysmetria and decomposition of movement. Okay, you see, and also the pathway is not normal in case of cerebellar lesion. Okay, so finger will move in some haphazard way and ultimately come to your nose, right? So dysmetria and decomposition of movement. Okay, very commonly we can test that. We can ask the patient sitting in your clinic, you can ask the patient to do something. Okay, take the pen from the table or simply show me your nose. So in this way, very easily we can diagnose the patient of cerebellar lesion. Okay, what else? Okay, so this is the term you need to remember, dysdiadochokinesia. Dysdiadochokinesia. So what is that? So a normal person is able to do repeated alternate movement. Okay, now what is repeated alternate movement? We can test the patient by simply doing supination and pronation in a sequence. Okay, if I ask the patient to do supination and pronation in a sequence, okay, so say for example, I am asking the patient to do supination pronation. Okay, fast, okay, very fast. We will ask the patient to do this, pronation, supination, right? We will ask the patient to do this. So a normal person will be able to do this very fast, okay, but in case of cerebellar lesion, first of all the patient will be doing it very slowly. Now once you hurry, faster, the patient will be doing, okay, so repeated alternate movement. What is dysdiadochokinesia? Dysdiadochokinesia is inability to perform repeated alternate movement. Okay, the term dysdiadochokinesia means inability to perform repeated alternate movement, right? What else? Ataxia. Have you heard the name ataxia? Where? What is ataxia? If you have heard the name ataxia, where have you seen it or where have you heard it? Ataxia mane ki? Very nice. Vitamin B12 deficiency. Yes, it may cause ataxia. How? Do you know how it can cause? Seizures in the muscle. No, unfortunately this is not true. But yes, vitamin B12 deficiency can cause ataxia. Okay. Have you seen people drunken? Have you seen how they walk? Okay. Almost they will fall, right? So, in motor system examination, when we examine the patient under central nervous system examination, you are doing with central nervous system right now, no? In your practical. Okay, under which higher function examination is over. Right now you are dealing with cranial nerve examination of cranial nerves. But there are many components under central nervous system examination. One is your higher function examination. Next is sensory system examination. Next is motor system examination. Then comes the examination of cranial nerves. Okay. So during motor system examination, we check many points. Okay. Central nervous system examination is divided into 4 categories, right? Sensory system examination, motor system examination, higher function examination, and examination of cranial nerves. Okay. And under motor system examination, we check many points like the bulk of the muscle, the tone of the muscle, okay, gait, okay, gait, reflexes, any abnormal movement, all these things we check, okay. So one point, major point is gait. Whenever the patient is entering to your clinic, okay, without talking anything, without taking history from the patient, you can come to your diagnosis. How the patient is walking, okay, walking style of the patient. You can diagnose a patient of osteoarthritis, you can diagnose a patient of hemiplegia or stroke, right? You can diagnose a patient of cerebellar lesion as well, okay. So simply by observing how the patient is walking, okay, how the patient is walking, different types of gait, okay. Sometimes patient may walk in this way. Okay. Sometimes patient will rotate one leg in this way. Okay. Osteoarthritis patients will walk in this way. Okay. So simply by watching how the patient is walking, right, you can diagnose many things, many things. Gait is so much important. So right now we will discuss how the gait will be affected in a patient of cerebellar lesion. Okay. Once there is lesion or damage in the cerebellum, how the patient will walk. Okay. So it is typically ataxic gait or drunken gait. Okay. Exactly similar to the patient who is alcohol intoxicated. Okay. This type of gait may happen in a patient of cerebellar lesion. So now tell me why there will be ataxic gait or drunken gait in a patient of cerebellar lesion. Any idea? Yes. Yes. Because cerebellum takes information from all your muscles through the spinal cord. Okay. Cerebellum takes information from all your muscles and it is called proprioceptive information. Proprioceptive information. What is proprioception? Any idea what is proprioception? These things are being difficult because you have not done yet sensory system examination and motor system examination, right? So একটু তোমাদের বলে দিতেই হবে. So during sensory system examination we check different sensation, right? We check different sensation. How many sensation you know? How many sensations you know? Touch sensation, temperature, yes, pressure sensation, anything else? Taste sensation, yes, that is a special sense. Anything else? Vibration. Okay, if I strike a tuning fork and hold it to your head, you can sense it is vibrating, right? So you have vibration sense as well. Okay. Another very important sensation we frequently miss or you are not telling or you are not aware of, which is quite subconscious, is your proprioception. Okay, we call it proprioception. Okay, the meaning of proprioception means joint position sense. Okay, it is a very interesting sensation and that we can test. Proprioception. What is proprioception? It is a sensation. Okay, for touch sensation you have a nerve, you have a neuron. Okay, for temperature sensation again you have a different types of neuron. For pressure sensation, for vibration sensation, for each type of sensation you have a separate kind of neuron. Okay, and there are classification of those neurons as well. We will talk sometime in subsequent classes. There are different types of neurons. Some neurons will carry your touch sensation to your brain. Some neurons will carry your pain sensation to your brain, right? Some neurons will carry your proprioception. Okay, these are alpha neurons. Okay, neurons are classified as A alpha, A beta, A gamma, A delta, B and C. Okay, I am not imposing classification right now because it will be burden for you. Okay, so there are separate set of neurons that carry your proprioception. Okay, separate set of neurons that carry your proprioception to your brain. What is that proprioception? It is joint position sense. That means, see, if this is my position in the three-dimensional space, here is my wrist joint. Okay, it has got a particular location in this three-dimensional. If you see, this is x-axis, this is y-axis, this is z-axis. So in this three-dimensional space, there is a particular position where my wrist joint is, right? So I know, even if I may close my eyes, I know my wrist joint is here, my knee joint is here. Even if I close my eyes, I know where my joints are, right? And this sensation is called proprioception. Clear? Even if you close your eyes, you know where your joints are located. Here is my shoulder joint left, here is my shoulder joint right. Okay, here is my spine, here is my wrist joint, here is my this wrist joint, here is my elbow. I know everything, even if I close my eyes. Okay, this location of individual joint in a three-dimensional space, okay, is your proprioception, and that sensation you have, okay, and there is a particular nerve. If I cut those nerves, you will not be able to know where your joints are. Getting my point? If I cut those nerves or any injury there, any disease there that destroys those nerves, okay, that nerves runs through the posterior part of your spinal cord. It is called posterior column, okay. This posterior column is composed of the nerves which takes your proprioception to your brain, okay. So if there is any disease in your posterior column affects the nerves which carry proprioception, okay, you will not be able to know where your joints are located in the three-dimensional space. It happens in syphilis, tabes dorsalis, syringomyelia. There are different diseases where it can happen, right? And another thing is vitamin B12 deficiency. Vitamin B12, which is responsible for myelin sheath formation, okay. Vitamin B12 is responsible for myelin sheath formation, and those nerves in the posterior column, they are thick nerve. They have got myelin sheath, okay. So once vitamin B12 is deficient, significant deficiency of vitamin B12, those myelin sheath will be lost, and those fibers, those nerve fibers will not work, and your proprioception will be lost, okay. So how a patient of proprioception loss will behave, okay. Similar to cerebellar lesion, these patients with proprioception loss will also have ataxia, drunken gait, okay. And we can test this simply by doing a very simple examination in your clinic. We call it Romberg test, okay. We call it Romberg test. How to do that? How to do that? Simply ask the patient to stand still, okay. Ask the patient to stand still. So the patient is normal, standing. Now you ask the patient to close his or her eyes. Patient will fall, okay. Patient will fall, okay. So this is due to proprioception loss, and we call it sensory ataxia. There are two different types of ataxia. One is sensory ataxia and another is motor ataxia, okay. So ataxia can happen due to cerebellar lesion, number one, and ataxia can also happen when the nerve fibers that carry your proprioception are lost, are damaged, right. When ataxia is due to cerebellar lesion, we call it motor ataxia. When ataxia is due to proprioception loss, due to lesion in the spinal cord, due to damage in the spinal cord posterior column, we call it sensory ataxia, okay. So proprioception মানে কি বললাম, আমার প্রত্যেকটা জয়েন্ট কোথায় কোথায় আছে থ্রি ডাইমেনশনাল স্পেসে আমি জানি, ঠিক আছে। যদি না জানি, মানে আমার প্রপ্রিওসেপশন যদি লস্ট থাকে, তাহলে আমাকে দেখে বলতে হবে ইয়েস আমার রিস্ট জয়েন্ট এখানে আছে, ইয়েস আমার নি জয়েন্ট এখানে আছে, দেখে বলতে হবে, ওকে। সো ইনিশিয়ালি দ্য পেশেন্ট ওয়াজ স্ট্যান্ডিং ওয়েল, পেশেন্ট ওয়াজ নট ফলিং, বিকজ পেশেন্ট দেখতে পাচ্ছে তার কোন জয়েন্ট কোথায় আছে। বাট ওয়ান্স ইউ আস্ক দ্য পেশেন্ট টু ক্লোজ হিজ অর হার আইজ, পেশেন্ট ইমিডিয়েটলি ফলস, right? This is sensory ataxia. And if it is cerebellar ataxia, doesn't matter eyes are open or closed, the patient will fall, okay. There will be swaying and patient will fall, okay. Motor ataxia, clear? So this is how whenever the patient is ataxic, just like drunken, okay, the patient is moving haphazardly, right, okay. Then you need to test if the patient is not alcohol intoxicated. You need to check whether this ataxia is due to cerebellum problem or due to posterior column problem, okay. If the patient is falling only after closing eyes, then it is a case of sensory ataxia. So ataxia is defined as errors in the rate, range and direction of movement. Okay? তাহলে the signs এছাড়াও কি হতে পারে অ্যাটাক্সিয়া, এছাড়াও কি হতে পারে slurred speech or scanning speech, slurred speech, ওকে, কথা কেটে কেটে যাওয়া, রাইট, slurred speech। আচ্ছা, আর কি হতে পারে, একটা মোটর সাইন আছে, ইট ইজ নি জার্ক, ইউ নো, অল অফ ইউ নো নি জার্ক, যদিও মোটর সিস্টেম এক্সামিনেশন পড়া হয়নি, নি জার্ক। ওকে, ইন cerebellar lesion there is usually hypotonia, muscle tone is low, okay, hypotonia, muscle tone is low, as a result knee jerk will be pendular type of knee jerk. Anyway, these things we will be explaining again in your practical classes, right? Okay, so to repeat, cerebellar signs: number 1, delay in initiation of movement; number 2, dysmetria and decomposition of movement; number 3, dysdiadochokinesia or inability to perform repeated alternate movement; then ataxia, it is a very typical ataxia which can be differentiated from sensory ataxia, which is due to lesion in the posterior column. Okay, then tremor, already discussed to you what is tremor. Okay, now definition of tremor you should remember, it is high frequency intermittency in the resistance of movement, tremor. And different types of tremor we had already discussed yesterday. Okay, starting from tremor in your anxiety, just during the examination there is tremor, this is due to anxiety. Okay, tremor in hyperthyroid patient. Okay, resting tremor in case of Parkinson's disease, and very typical intention tremor in cerebellar disease, right? Next is slurred and scanning speech, and also remember pendular knee jerk. A typical pendular knee jerk is seen in cerebellar lesion due to hypotonia, okay, or reduced muscle tone. So these are all features of cerebellar lesion. Okay, just remember those lesions. Once you see a patient of cerebellar lesion, then you will be able to remember all those things very easily. Okay, now we are coming to the connections. Okay, connections we need to project. The cerebellar connection. In cerebellum we have 3 layers, 3, 4, 5. If you remember, 3 layers of cerebellum, 4 deep nuclei of cerebellum and 5 cells, right? Already been discussed yesterday. Just a recap, cerebellum has 3 layers, 4 deep nuclei and 5 cells. Okay, 3 layers are the outer molecular layer, middle Purkinje cell layer and inner granular layer, and 4 deep nuclei are there: dentate, globose, vestigial, emboliform, right? And 5 cells: Purkinje cell, granular cell, Golgi cell, stellate cell and basket cell. Okay, so 3, 4, 5, mnemonic 3, 4, 5. You remember 3 layers, 4 deep nuclei and 5 cells. Very important, very frequently it comes in the examination. The basic anatomy, we will study this in anatomy as well and also in physiology, right? Okay, and here is the cerebellum. You see the major 3 functional subdivision. In the middle it is spinocerebellum. In the middle it is spinocerebellum, and on the sides 2 hemisphere they are called cerebrocerebellum, and below it is vestibulocerebellum. Okay, so this is grossly the basic anatomy of cerebellum. In anatomy you will study far more detail about cerebellum. Okay, so now another question that is very frequently comes in your professional examination is the input and output of cerebellum. That means what are the nerve fibers that are coming to cerebellum and what are the nerve fibers that are ejecting from cerebellum. Okay, so input and output, cerebellar input and cerebellar output. Okay, so this is the easiest way to remember cerebellar input and output. कहाँ से nerve cerebellum में आ रहा है और cerebellum से exit कर रहा है, right? Okay, so cerebellar input. So from cerebellar cortex, from cerebral cortex, contralateral cerebral cortex, opposite cerebral cortex. Okay, so from opposite cerebral cortex through middle cerebral peduncle, it comes to cerebellum. Then proprioceptive information, I just told, proprioceptive information. Your cerebellum takes your proprioceptive information. right, from your sensory system, right? So the proprioceptive information through spinal cord, cerebellum receives it through inferior cerebellar peduncle, right? Okay, so cerebellum receives input from contralateral cerebral cortex. Okay, so your right cerebellum receives input from left cerebral cortex, contralateral cerebral cortex. This is one. Another is it takes information from spinal cord. What information? Proprioceptive information. You are taking your joint position sense, this information is also sent to cerebellum, right? And from inner ear vestibulocochlear nerve, if it is done already, from inner ear vestibulocochlear nerve, it sends fibers through vestibular nuclei, and from vestibular nuclei information goes to the cerebellum flocculonodular lobe. This one is flocculonodular lobe, and from this it comes back again to vestibular nuclei. Okay, so this is the input and output of cerebellum in the most easiest way. Okay, because for you right now it will be very difficult for you to remember the names of the tracts, which comes to cerebellum and which moves away from the cerebellum, the afferent tract and efferent tract. Okay, so if this question comes, write the input and output of cerebellum, if you draw this, at least I guess you will be given 90% marks, right? But if you are able to name the tracts, the tracts are also here. I am showing you the names of the tracts. Yes, here is the names of the tract. Okay, this is directly taken from Ganong's physiology, right? So vestibulocerebellar, dorsal spinocerebellar, ventral spinocerebellar, cuneo-cerebellar, tectocerebellar, pontocerebellar, and olivocerebellar. Okay, vestibulocerebellar means from vestibular nuclei to cerebellum. Okay, spinocerebellar means spinal cord to cerebellum. In this way, if you are able to name the tracts, you will be given 100% marks, or else you can simply draw this picture to show the cerebellar input and cerebellar output, right? This is the easiest way. If you draw this picture, that is enough, I guess, for now. Yes? Okay. So the question is, what are the nerve fibers that are coming to cerebellum and what are the nerve fibers that are exiting from cerebellum? This is the question, simple question. क्या input है cerebellum में, क्या output है, right? Okay. So cerebellum receives input from contralateral cortex, opposite cortex. Right cerebellum receives input from left cerebral cortex, right? Through middle cerebral peduncle. And proprioceptive information, what I told, your joint position sense, okay, your joint position sense runs through spinal cord, okay, and from there, from spinal cord, also nerve fiber goes to cerebellum through inferior cerebellar peduncle, right? So proprioceptive information through spinal cord goes to cerebellum through inferior cerebral peduncle, and from your inner ear vestibulocochlear nerve, it sends nerve fiber to vestibular nuclei, and from vestibular nuclei it comes to flocculonodular lobe, and from flocculonodular lobe it also again comes back to vestibular nuclei. Okay, so vestibular nuclei, both input and output. Okay, this is same vestibular nuclei, right? It comes and comes back to vestibular nuclei, as because we have separated input and output on different directions. So vestibular nuclei is written twice, here and here. Okay, so this is the thing, and cerebellum has got all the deep nuclei. From deep nuclei through Purkinje cells it goes to contralateral cortex. তাহলে contralateral cortex থেকে ফাইবার আসেও, আবার contralateral cortex এ ফাইবার যায়ও, ঠিক আছে? এই জায়গাটা একটু মুখস্থ করতে হবে, ঠিক আছে? There is no way right now. Gradually you will be able to remember. Okay, ठीक है? Now we are coming to the most important long question for you, that drawing these connections. Okay, drawing this connection. Remember, Purkinje cell is the most important cell in cerebellum, Purkinje cell, and that is the largest cell. So here you see the Purkinje cell, PC. It is the largest cell, right? And it is connected in a different way through other cells like the basket cell, granular cell, Golgi cell. Okay. So these are 4 major cells. Okay. PC, BC, GR, GC. Purkinje cell, basket cell, granular cell, and Golgi cell. Right? Okay. 2 different types of fibers are there. One is climbing fiber. Okay. So Purkinje cell, it receives input from climbing fibers. Okay, this is called climbing fibers, and this is called Mosey fibers. Okay, climbing fibers directly converge onto Purkinje cells, and Mosey fibers through different cells, it indirectly converge onto Purkinje cell. Okay, to simplify this, okay, let it simplify. ঠিক আছে, দুদিকে দুরকম ফাইবার আছে, এদিকে ক্লাইম্বিং ফাইবার আছে, জাস্ট এই জিনিসটা বুঝতে হবে, এদিকে ক্লাইম্বিং ফাইবার আছে আর এদিকে মসি ফাইবারস আছে, রাইট? ক্লাইম্বিং ফাইবারস এন্ড মসি ফাইবারস. The target is both climbing fibers and mosey fiber will converge onto Purkinje cell, right? So you see, climbing fiber is directly converging onto Purkinje cell, and mosey fibers, they are not directly converging into Purkinje cell, but মজি ফাইবারস প্রথমে গ্র্যানুলার সেলে আসছে, গ্র্যানুলার সেল থেকে গলগি সেলে আসছে, গলগি সেল থেকে আবার পার্কিনজি সেলে আসছে, ঠিক আছে, থ্রু ডিফারেন্ট সেল আলটিমেটলি পার্কিনজি সেলে আসছে, রাইট? ওকে, সো পার্কিনজি সেল ইজ দি মেজর সেল ইন দি সার্কিট, cerebellar circuitry, which receives input from climbing fibers and mosey fibers. এবার এই ক্লাইম্বিং ফাইবারস আর মজি ফাইবারস এগুলো আসে কোথা থেকে, রাইট? সো সি দিস, লার্নিং ইন cerebellum. How learning takes place. Yesterday we talked that in your learning process, whatever motor learning you are doing, learning may be riding a bicycle, motor learning, different motor learning we do, na, right? So like riding a bicycle, swimming, এগুলো তো একদিনে শেখা যায় না, আস্তে আস্তে প্র্যাকটিস করতে করতে শিখতে হয়, রাইট? Or driving a car, okay, or horse riding, whatever. These are all motor learning. Gradually you learn, okay? And the organ which helps you to do that is your cerebellum. Okay, and the mechanism is LTD, that is long term depression, okay, or synaptic plasticity. আমি জানি যারা নতুন আজকে এসে তারা হয়তো অনেকটা বুঝতে পারছে না, ঠিক আছে? ওকে, সো লং টার্ম পোটেনশিয়েশন অ্যান্ড লং টার্ম ডিপ্রেশন দুরকম, লং টার্ম সাইন্যাপটিক প্লাস্টিসিটি আছে। লং টার্ম পোটেনশিয়েশন কাজে লাগে মেমোরি ফরমেশনের জন্য, আর লং টার্ম ডিপ্রেশন কাজে লাগে লার্নিং এর জন্য, মোটর লার্নিং এর জন্য। and this motor learning takes place in your cerebellum, okay, in your cerebellum. So how motor learning takes place? So let us assume an example of bicycle riding. You are starting today, okay, you are starting today with the bicycle, but you are falling, you have no balance, you have no proper coordination of movement, right? Your muscles are not cooperating, your nerves are not cooperating, and you are falling repeatedly, okay. So after 2 days of practice, at least you are not falling, you are supporting yourself, okay, and gradually at the end of 1 month, yes, you are riding bicycle smoothly, right? So this is how things takes place. So how in the circuitry of cerebellum with this PC, BC, GR, GC, Purkinje cell, Golgi cell, basket cell, whatever cells are there, এখানে কিছু চেঞ্জেস হচ্ছে, তার জন্য we learn, okay. So this is the simplified thing, right? This is the simplified thing. This is climbing fiber unit, climbing fiber input. It comes from olive, okay. Olive, you know, olivary nucleus, brain পড়া হয়েছে অ্যানাটমিতে, okay. Okay, so olivary nucleus is there, and this is non-olive structures. All non-olive structures means all the proprioceptive input from your spinal cord. Spinal cord থেকে যা information আছে সব information cerebellum নেয়, right? So all other information coming from non-olive through mossy fibers. Mossy fibers directly Purkinje cell এ আসছে না, mossy fiber granular cell এ convert করছে, granular cell এসে আবার Purkinje cell এ convert করছে, right? কিন্তু olive থেকে CFI বা climbing fiber unit, climbing fiber input, এটা directly Purkinje cell এ আসছে, clear? So basically Purkinje cell has got 2 inputs. One is CFI called climbing fiber input, and another is MFI called mossy fiber input. Climbing fiber input is direct on the Purkinje cell, and Mosby fiber input is through granular cell. Okay, both have positive input. That means the neurotransmitter which is secreted here and here is glutamate. Yes, very nice. The neurotransmitter secreted is glutamate. Okay. Okay. Now, whenever you are starting to ride a bicycle, or you are trying to learn, okay. So from non-olive structures, matlab from spinal cord, from all your muscles, whatever muscles are involved in riding a bicycle, সমস্ত muscle থেকে information spinal cord হয়ে non-olive structures থেকে spinal cord হয়ে granular cell দিয়ে Purkinje cell এ আসছে. Okay, and it creates simple spikes. Okay, it creates simple spikes. Okay, so at the beginning when you are learning throughout a period of 1 month, okay, throughout a period of say for example 1 month, you are learning this climbing fiber input from olives comes to Purkinje cell and it smoothens the spikes. So climbing fiber, function of climbing fiber input is to smoothen all the simple spikes. Okay, so if I give you example, so there is a big electrophysiology, you don't need to learn that much, but to be simple, so you have MFI, Mosby fiber input and climbing fiber input, right, to the Purkinje cell. This is Purkinje cell, right? So Mosby fiber input is simple spike. Okay. So this simple spike is of different size, different length. Okay, on the Purkinje cell. But when climbing fiber input, it converges on the Purkinje cell, it smoothens up all the things. Okay, so it smoothens up all the things and it is converted to correct. Okay, so from this simple spike to this smooth movement, okay, this smoothening effect, it occurs due to climbing fiber input. Okay, so initially when you are learning, there are simple spikes and that are of different heights. Okay, different heights, different duration. So basically Mosby fiber input er opor climbing fiber input is like ironing. Kapore onek bhaj ache, right? So ironing is like CFI input, climbing fiber input. Okay, the role of climbing fiber is to run an iron over Mosby fiber input. So at the beginning of learning, there are only simple spike. আর যখন সিম্পল স্পাইক গুলো একদম স্মুথ হয়ে যাবে তার মানে তুমি শিখে গেছো. ওকে, and further there is no requirement of CFI. So CFI works or climbing fiber input works only during the period of learning of 1 month. After 1 month, when you are learned already, then only there is Mosby fiber input and that are already smooth. Long term depression has taken place. Okay, and you know the mechanism of long term depression, that is reduction in the AMPA receptors. Okay, that is discussed yesterday. So see this climbing fiber input, it is large complex spike on Purkinje cell, and Mosby fiber input, it is simple spike on Purkinje cell. CFI, it occurs at the beginning of learning. CFI causes smoothing over MFI just like ironing wrinkled clothes, right? CFI causes smoothing over MFI just like ironing a wrinkled cloth, right? CFI reduces errors and regularizes MFI. Okay, and CFI causes EPSP. This part is not required for you. CFI is basically causing long-term depression. Okay, CFI is basically causing long-term depression of the Purkinje cell, and that is responsible for your learning. Clear? Okay, this is another question for you. Short note: mechanism of learning, mechanism of motor learning in cerebellum. Okay, mechanism of motor learning in cerebellum. Yes? Yes, EPSP means excitatory post synaptic potential. Okay, EPS পড়া হয়নি তো এখনো, so that is why I had skipped EPSP and IPSP তোমাদের এখনো পড়া হয়নি, right? So EPSP means excitatory post synaptic potential and IPSP means inhibitory post synaptic potential. Okay, chalo, that's it. So from cerebellum, questions are cerebellar circuitry, you need to draw, right? You need to draw the connection between Purkinje cell, basket cell, Golgi cell, granular cell, all the connections you need to draw, the cloimbing fiber input, Mosey fiber input. Okay, this is must for you. This figure, it is already given in your textbook, whatever textbook you are studying. Okay, try drawing this and practice this, because very frequently it will come, the cerebellar connections in cerebellum. Okay, if the question is connections in cerebellum, you need to draw this internal connection, and also you need to mention the input and output of cerebellum. Or the question may come as separately, what are the inputs and outputs of cerebellum? Or this may come, question comes as in a different way, what are the afferent fibers and efferent fibers of cerebellum? Okay, and finally, what is the mechanism of learning in cerebellum? Okay, and in practical, questions are, what are cerebellar signs? Okay, what are cerebellar signs in practical? What are cerebellar signs? Okay, cerebellar signs ki ache, jemon intention tremor, slurred speech, okay, pendular knee jerk, dysmetria, dysdiadochokinesia, right, tremor, ataxia. Okay, so these are all cerebellar signs. Okay, and how to examine a patient, motor system ota to pore hobe. Okay, motor system examination, right? Okay, chalo, that's it.